All right, guys, next up in oxygen delivery is going to be our Cpap. Currently, right now, there's about 3 different devices that we use for Cpap for pre-hospital. We have the partially disposable, which is the Cpap OS, machine itself with the circuit. This is the part that is disposable. We have the O2, which the whole thing is disposable. And then we also have the pulmodine, also completely disposable. So when we do Cpap, we're doing this for patients that often have respiratory distress, pulmonary edema, fluid built up in the lungs, some cases for reactive airway, depending on your system. Tends to work pretty well for what we need to use it for. So first things first, what we need to do is we need to assess our patients. We need to have our PPE on. We need to greet our patient. We need to assess their level of consciousness and their respiratory status as well. So we're going to come up. A lot of patients with respiratory distress are going to be tachypnic. We should be seeing some possible retractions in the intercostals, usually often in like a tripod position, just in a very uncomfortable state. So the first thing we want to do is we want to make sure that we're checking how fast their respirations are or how slow. We want to check for rate, depth, and effort. We also want to listen to their lung sounds. So a lot of patients that have congested heart failure will often present with crackles or rales, very wet sounding lung sounds. A lot of patients that have chronic bronchitis will usually have more of like that bronchi kind of sound with a lot of mucus that's built up in their chest. So after we assess their lung sounds, assess their SpO2, get another set of vitals. If they're super hypoxic, we want to go ahead and put them onto a non-rebreather. As we discussed in the other video, make sure that we connect to the tank. We want to make sure that we're about 10 to 15 liters per minute, making sure that the reservoir bag is filled all the way up. Turn it on. Make sure this bag is completely inflated. Place it on our patient. Also, it will be a good time to also add your end-tidal CO2, which for this guy, because he does not have ears, we're just kind of secured for that. We also want to get a good sample history from family or the patient, make sure we're getting good medical history as well. So for the purposes of the demonstration, we're going to use the Cpap OS, which is this machine right here. As we're also assessing your ABCs, make sure that the airway is patent, it's open, it's not obstructed. Make sure that if you do find any issues with that we fix it and move on. So for the Cpap OS, we have the actual device itself that generates our PEEP. We have a rather long set of oxygen hose. This will actually go to the bypass of the regulator, which I'll show you in a sec. And we have the disposable Cpap circuit with masks. Masks come in small, medium, and large sizes as well. For this one, we're going to be using the medium. So, make sure that we're also doing appropriate monitoring for the patient, make sure that we're reading a full set of vitals, making sure that we do have them on the end tidal, keep monitoring their SpO2. There are some contraindications for Cpap. Respiratory arrest, the patient must be breathing on their own. If they have agonal respirations, this is also considered a contraindication, same thing with hypoventilation. They must be conscious, they must be able to follow your commands. Cardiogenic shock is also another symptom. Chest trauma, such as a pneumothorax, and then facial trauma and burns are also considered contraindications for these patients. So they must be awake, they must be able to track you, they must be able to follow commands, they must be breathing on their own. Also, at this point, we want to make sure that we get consent from the patient to put them on Cpap. Cpap is positive pressure, so once it's hooked up to the oxygen tank, it's going to be providing a constant positive pressure into the lungs. It feels very uncomfortable for a lot of patients. Patients who are on, who have sleep apnea, that are on BiPAP every night when they're asleep, are a little bit more used to this. But an average patient that is not on these types of devices, This will feel like they have their head sticking out of a car window going about 60 miles an hour down the highway. So setting up the device itself is actually pretty easy. So we want to make sure that our mask is connected to the circuit right here. We have a HEPA filter as well that will come in the packaging. That goes in this rotating section. This port connects right here. That yellow cap is. And how that goes in is that cap pops off. You want to insert it right there and twist to make sure it's locked into place. Set your dial all the way down so that whenever you're turning it on, you're not blasting them right away out of the gate. So at this point, we're going to take the oxygen cable that goes off of the machine itself, and we're going to plug it right into the bypass of the regulator. And all that the bypass is doing is once this section is connected to the tank, oxygen is going to come out of these two ports first, and they have one-way valves in them, so whenever you connect the tank, it's going to activate that one-way valve, and it's going to allow oxygen to go through the hose. And it bypasses the actual regulator where the non-rebreather is hooked up. So we're going to tighten that in right in here. Whenever this is connected, that's whenever the actual machine will turn on. It's very loud. It's going to sound like air is rushing through it. You're also going to hear every leak that's in the connection ports, so make sure that everything is tightened down really well. From here, we're going to instruct the patient, and we're going to inform them that we're going to put the mask on their face. So sir, we're going to place you on Cpap. It's going to be a little bit uncomfortable. It's going to feel like air is rushing in. It might be a little bit more difficult to breathe out. So before we fully secure the mask, I usually like to have the patient bring the mask up to the patient, hold their head in place, and have them take a few deep breaths to see how they tolerate the machine. If they do okay, because the goal is that this foam section, we want this section to seal very nicely around the skin because we don't want air leaking out. So we want to be able to get a nice, good seal. Once they have a good seal, and if they're able to tolerate this well enough, we'll secure the mask to the back of their head. The straps that we use are like so. There's little holes on each leg of the strap, and that will secure in each of the pins that are on all four parts of the mask. And as we're securing, I'm still asking my patient, how are they doing with the mask? Because if they aren't tolerating this, then we need to probably do either the non-rebreather with high flow, or we need to even consider bagging the patient depending on the level of their distress. So once it's fully secure, again, we're going to reassess how the patient is tolerating the therapy. We're also going to set this little dial that's on the machine to about 5 centimeters of H2O, and that is considered 5P, and that is our starting point. Reassess our patient, see how they're doing. We want to reassess their lung sounds. We want to reassess all their vitals. If they are tolerating it fine, and the machine is secure, this is the point that we would probably get them onto the gurney if we haven't already done so and initiate transport. These are patients that we want to make sure that we're checking vital signs every 3 to 5 minutes because of the possibility of chest trauma. If we're not getting much improvement with the machine, and after our reassessment, we can start going up on the PEEP in increments. For the pulmodine right here, usually goes in increments of 5, 7.5, and then 10 PEEP. So we can start kind of judging that as we go. Each time that we up the pressure for the patient, we need to make sure that we are reassessing all our vitals, reassess our lung sounds, reassessing capno, SpO2. And that is Cpap. Something else with Cpap as well that we talked about in another video with nib treatment, we can also do inline nebs with the Cpap as well. So key for Cpap is making sure, 1, we have a good seal, 2, that there's no contraindications. and making sure that the patient is tolerating the therapy. Alrighty guys, quick video on the O2 disposable Cpap. So the machine itself is actually very simple. We got a kind of a pressure valve connected to an oxygen line. Right here typically would be a pressure gauge that you would adjust, or that you would be able to see exactly what your pressure is as the patient is breathing in and out. These are the devices currently that Albuquerque Fire and Rescue are using on their rescues. Super simple setup, place the mask in, the actual PEEP device right here, and then the oxygen line. Unlike the Pulmodyne and the Cpap OS, this connects to the actual oxygen regulator. You're going to set that bad boy up like you would a non-rebreather, nasal cannula, a neb, or anything like that. And then the PEEP is adjusted by the regulator itself. So same way with introducing it to the patient, you want to make sure that you explain to them what Cpap is, what it does, explain that it's going to be a little bit uncomfortable. But as you are setting it up, same thing, the mask itself is equivalent to a BVM mask. So we want to make sure that we introduce the patient to it, we want to make sure that there's a good seal, and that they're tolerating it before we secure it. The Pulmodyne is used with Albuquerque ambulance. One long disposable circuit. Mask usually comes off and is in a separate bag. Unlike the O2 Cpap, this will connect to the oxygen bypass part of the regulator. So whenever you connect that, you're going to start hearing the device working. These devices are very loud. It's going to sound like air is leaking through it. And as you extend the corrugated tubing, the machine itself actually starts to whistle. So you're going to hook this up. Your PEEP is adjusted with this white knob. And we have it set at about 5 right now. And then to adjust it, we just turn that. And then how we know which PEEP we're at is this little white tip right here will be measuring the different colors that are on that. So these come in 5 PEEP, 7.5, and 10 PEEP. So we'll start off with 5. We're going to connect our mask right here. This port right down here is for a nebulizer treatment to do inline net. We're going to connect. The straps are usually already connected. Same thing with the other devices as well. We want to make sure that we introduce the patient to it. We want to explain to them it's going to be uncomfortable. And before we get it secured in, we want to make sure that they're able to tolerate it. So same way, we'll bring it up, get a good seal, and instruct the patient to take a few deep breaths in. If they are able to tolerate it, at that point, we will secure the mask. This top part is adjustable so that it sits nicely across the forehead. And then we have our side straps. The Pulmodyne is probably more similar to commercial BiPAPs, Cpaps for sleep apnea use. So if you have a patient that is used to being on BiPAP, this might be a little bit more comfort for them. And as always, anytime that you readjust your PEEP, we need to be reassessing our patients. We need to be reassessing these patients every 3 to 5 minutes.